when we look to the EBMT recommendations and indication for transplant in classical Hodgkin lymphoma, we can see that allogeneic stem cell transplant is a standard of care for patients relapsing after autotransplant with that are responsive to salvage following relapse. That was the case in the recommendations and indication in 2019 and is still the case in 2022. Yet, if we look to the EBMT registry, we can see a decline over time in the number of allografted patients. And there may be different reasons to explain this decline over time. One of them would be that people are thinking that there are more effective and less toxic alternatives to allotransplant. However, the reason for the decline over time that is quite obvious is that we have more effective drugs in first-line treatment of Hodgkin lymphoma, more effective drugs in first relapse, and as such, less candidate for allogeneic transplant. So when we talk about the new drugs, these are mostly two categories. We have Brentuximab vedotin, which is an anti-CD30 antibody drug conjugate. And this drug has been incorporated in first-line treatment, and BV in frontline treatment of advanced stage classical Hodgkin lymphoma improves overall survival in adult and pediatric patients. And the second class of drugs or family of drugs are checkpoint inhibitors targeting PD-1. And actually, we have frequent PD-1 ligand genetic alterations in classical Hodgkin lymphoma that are central to its pathogenesis. And recent data in frontline treatment have shown, presented at the last ASCO meeting, have shown improved PFS at 1 year with nivolumab combined with AVD compared to Brentuximab combined with ABVD. And we also have data for pembrolizumab followed by AVD, as well as pembrolizumab combined with chemotherapy. So altogether, this has resulted in a higher rate of cure in first-line treatment, and then less candidate for first salvage. And for first salvage, the standard of care is autologous stem cell transplant following salvage therapy, and patients should respond to salvage therapy to obtain the best response before autotransplant. And actually, in the transplant setting, these new monoclonal antibodies, whether Brentuximab vedotin or checkpoint inhibitors, can be used as part of the salvage before auto, maintenance post-auto, salvage for relapse post-auto, bridge to allogeneic transplant, as well as salvage post-allotransplant. And when we look to regimen combining Brentuximab vedotin with salvage chemotherapy before autotransplant, we can see that compared to salvage chemotherapy alone, the complete remission rate, the PET negativity or metabolic CR, has doubled from 35% with chemo to around 70% or more with BV combined with chemo. And we also have data with checkpoint inhibitors such as pembrolizumab combined with GvHD, resulting in outstanding progression-free survival, as well as some chemo-free regimen, for example, nivolumab combined with Brentuximab vedotin. And all of these regimen are resulting in a significantly improved cure after autotransplant, and hence less candidate for allotransplant. We also have consolidation strategies after autotransplant. So the ATHERA study have shown a significantly improved progression-free survival when using Brentuximab vedotin consolidation in high-risk patient, which is now standard of care, as well as very promising data consolidation with pembrolizumab or combination of Brentuximab and nivolumab maintenance post-auto, and with PFS exceeding 90%. So all of this, maybe a little bit long introduction, can explain that today we have much less candidate for allotransplant, much less patients relapsing after autotransplant that would be potential candidate for allotransplant. Yet we, within the EBMT, we have recently shown, that was published in Leukemia 2022, is a significant improvement in overall survival from relapse after autotransplant over the years. For example, the 4-year overall survival from the time of relapse post-auto has improved from 35% for patients who relapsed between 2006-2008 to more than 60% for patients who relapsed between 2015 and 2017. And this improvement in relapse post-auto was mostly visible for the early relapse within 12 months after auto, which historically had the poorer outcome following relapse. And however, when we look to the salvage strategies that was used for these patients relapsing after auto over time, we can see that a second transplant was realized in 43% of patients, predominantly allogeneic transplant in 86% of patients, and resulting in a plateau of survival at around 55%. And interestingly, the percentage of relapsing patients that were referred to allotransplant significantly increased over time. So we have, in recent years, much more patients referred to allotransplant in terms of percentage than in prior years, which means that currently, at least in Europe, maybe less in the US, but at least in Europe, when patients relapse after autotransplant, most of these patients are referred to allotransplant, even though, as I explained before, the number of patients relapsing after autotransplant has significantly dropped, explaining the decrease in transplant activity. And before allotransplant, patients should receive a salvage treatment to get a response before allotransplant. This is mandatory. And actually, this salvage is currently incorporating the new monoclonal antibodies. So with Brentuximab vedotin, the long-term follow-up has shown that around 20% of patients treated with BV for relapse post-auto are cured. Some of them, very few, but some of them were cured without additional allotransplant. So when we used to say that allogeneic transplant is the only curative modality for relapse post-auto, this is not true anymore. We can cure a small percentage of patients with Brentuximab vedotin, and the cure with BV is almost exclusively for patients who achieve complete remission with Brentuximab vedotin. And actually, we have shown previously with EBMT that BV can be used as a bridge to allotransplant, allowing heavily pretreated patients in a very large study, including more than 435 patients, allowing more heavily pretreated patients to receive an allotransplant with similar results to less pretreated patients, as well as with a decrease in chronic GvHD. And again, when looking to the EBMT registry over time, we have seen a significant increase in recent years of the use of BV over time, and BV for relapse post-auto resulted in 78% response rate and 56% for year overall survival. Similarly, for checkpoint inhibitors, for patients who relapse after auto and who are potential allogeneic transplant candidate, both nivolumab and pembrolizumab have shown a very high rate of response, and we have a significant improvement in overall survival. However, patients' progression-free survival is not that good. Patients continue to relapse over time with checkpoint inhibitors alone, and the EBMT registry 4-year overall survival was only 44% for patients treated with checkpoint inhibitor for relapse post-auto. However, this checkpoint inhibitor can safely be used as bridge to allogeneic transplant with a excellent outcome in terms of progression-free survival and overall survival. But we have to understand that we have a significant risk of GvHD for patients with prior exposure to checkpoint inhibitors before allogeneic transplant. And recently, we have data that post-transplant cyclophosphamide is mandatory for patients who receive an allotransplant following checkpoint inhibitors, resulting in a significant decrease in GvHD and mortality, even not only in the haploidentical transplant setting, but even in the match-unrelated donor setting. And actually, currently, the recommendation of allotransplant after checkpoint inhibitors is to hold PD-1 therapy for at least 6 weeks before allotransplant and to use post-transplant cyclophosphamide based GvHD prophylaxis. In conclusion, I would say that the introduction of BV and checkpoint inhibitors has changed the landscape of relapse refractory Hodgkin lymphoma. Autotransplant is still the standard of care for first relapse. BV and checkpoint inhibitor increasingly used before and after autotransplant. We have seen a steady increase over time in overall survival for patients in relapse after auto. Allogeneic transplant is a potentially curative strategy for patients who fail autotransplant. Allotransplant might be deferred in patients that achieve a CR with BV, for example, and BV and checkpoint inhibitors can be safely used before or after allotransplant with what we have seen in terms of time effect and post-transplant cyclophosphamide for for checkpoint inhibitors. Thank you for your attention.